Welcome to a new edition of Health Department Roundtable. I'm your host, Chris Schultz, and with me today is our Health Director, Marty Golightly.
Good evening.
Resident scientist, Tom Boulay. Tom, thanks for joining us today.
Pleasure.
So I asked you on because today we wanted to address the sequel to last year's surprise hit, COVID-19, the Delta variant. There's been a lot of misinformation and a lot of questions and a lot of confusion going around. So I'm hoping that maybe you can throw some science at us and clear things up.
I mean, I can try for sure. So thank you for having me. I do feel like it's important that I go through sort of the caveats at the top.
Tom, can I just real quick? Before you get into your amazing stuff, I just want to say that Tom is doing this out of the kindness of his heart. As a friend, he's been at every single or almost every single shot event we've had. If it wasn't been him, it's his equally or more so brilliant wife, who has been there at every shot clinic to answer questions that anybody had. So I want to say thanks again. Tom is a model of a science communicator, and I really appreciate you doing this, buddy. So, and with that, I'll step back and shut up.
Well, it's very kind of you. The nerd in me wants everybody to know, right, that I am a biologist. I am not a COVID expert, right? I'm following the news and the publications out of my own interest, right? Trying to understand what could happen to my parents, what could happen to my children. I do read the primary literature, and I'm going to share a little bit about what I understand the current situation is. I do not work for a vaccine manufacturer, right? I have no financial interest in a vaccine manufacturer. It's important to let people know that what I'm telling you is what I understand from my own understanding, and it doesn't come from anybody but me. So if I screwed up, it's me. Also, I'm not a physician. If you have a medical question about your particular circumstances or your parents or your children's particular circumstances, you should take those to your physician. Your physician should be able to answer those for you in your particular circumstance. What I plan to do today is just talk a little bit about what I'm seeing in the data and how I'm thinking about it. And hopefully that helps people understand a little bit more about sort of the deluge of information, frankly, that's coming out, right? There's been more information on COVID and the Delta variant published in the last 2 weeks than I've seen in months, right? So I've been trying to wade through it, and I will sort of share, like I said, how I think about it.
Excellent.
And so with that, I wouldn't be a nerd if I didn't bring slides.
I'm definitely proud of you for that one.
Thanks, buddy. And I'm gonna thumbs up if we can see this. Marty and Chris, thumbs. Okay, so what I wanted to go through real quick was Delta variant, right? I mean, it's kind of what's on in people's minds, although there are a couple of other variants out there. And so we should talk about what a variant is and what that means, what a breakthrough case is, right? Because there's a lot of talk about breakthrough cases, how the vaccines are doing, right? Everybody, like, we're one of the most vaccinated states in the country, right? What does that mean? And how are the vaccines holding the line? How is Delta different, right? Do we have to think about it differently or worry about it differently? And what does it mean going forward, right? So hopefully this will answer some of the questions. If not, then, we can get into it. And Chris and Marty, and let me know if there are things we want to stop and get into. So let's start with what a breakthrough case is, right? Because there's been a lot of talk about breakthrough cases. This slide is one of the slides that I showed last time I was on, right? This is actually the foundational data that Pfizer showed in order to get emergency approval for their vaccine. And this is one of the key graphics, right? What you see here is they did what's called a placebo-controlled trial. So they gave a group of people an injection of salt water that had nothing to do with COVID, and they gave a group of people the COVID vaccine. And what you see across the bottom is just days, and they were counting how many people got COVID, right? So the red is people that got the placebo and didn't really stop COVID, right? Everybody that group of people were progressed. So more and more people got COVID, and the blue line is the people that got the vaccine, right? And you could see this sort of dramatic separation between the red and the blue lines, right? It was one of the ways that they demonstrated that after about 11 days, you started to see a real pickup in immunity against the COVID vaccine or COVID virus. Now, sort of an important distinction here is that the green line is a line that I added, right? The green line is what would happen if the vaccine was 100% effective, right? As soon as you got the vaccine, if nobody ever got the COVID going forward, the blue line would sort of be flat, right? It would be along the green line, Would there be no cases of people who got the vaccine that got COVID? We have known from the outset that this didn't happen, right? There's a still small fraction of people that got the vaccine and still developed COVID, right? If you had a vaccine and developed COVID, you are, by definition, what's called a breakthrough case, right? The COVID has managed to break through and you've managed to get some symptoms of the infections of COVID. I think the important part here is breakthrough infections are not new. Right? I think that's really what I'm trying to communicate here is we've known, based on this data and the fact that the blue line is not flat, that breakthroughs were going to happen. Right? So it's not a new phenomenon. It's something that we knew kind of that we would have to deal with. Right? It's still a heck of a lot better than no vaccine along the red lines. But the idea that breakthroughs are happening is not a now phenomenon. It's not totally unexpected either. Right? It's just something we're going to have to deal with. So from definitionally, right, just a breakthrough case is someone who has the vaccine, developed COVID, but to some extent that is expected based on the parameters, based on the efficacy of this particular vaccine. And the Moderna vaccine, very similar sort of circumstance. So that's what a breakthrough case is. So here is how I think about where the vaccines are right now. I'll take it on the left side. So this is sort of follows the progression of a very severe case of COVID, right? Someone gets exposed to the virus starts to replicate in their system. They get to a point where they're able to transmit it to others, right? Typically, you are able to transmit it to others before you're symptomatic. Then the symptoms begin. Some people progress to severe infection and hospitalization and eventually death. Right? And we can kind of look at this progression from the perspective of the people that haven't got vaccinated and the people that have got vaccinated, and we can kind of see where some of the differences are, right? So one of the first things that I was reading, right, about this in terms of exposure to virus. So there are some people, presumably, that they get exposed to the virus and they're able to fight it off, right? It doesn't sort of take purchase in their system, start to replicate, and there are some people that aren't so lucky, right? They aren't able to fight it off. There was a study released, I think, Thursday of last week from the CDC, based on a population in Kentucky, which showed that people who had COVID previously, compared to people that got the vaccine, right? The people that got the vaccine were 2.3 times less likely to get reinfected, right? So the vaccine sort of has some frontline protection, seemingly, right? You're about 2.3 times less likely to get reinfected, even if you've had COVID in the past. So that's sort of the first line of defense, right? So the vaccines seem to be doing a good job of just fighting off the virus from the outset in some cases. Now, if the virus makes it into your system and gets purchased and starts to replicate, right? One of the really interesting things, and we'll talk about this a little bit later, that came out of the outbreak in Barnstable was that the people that are unvaccinated and people that were vaccinated, sort of the virus numbers in their blood, sometimes called viral titer, sort of reach the same levels, right? Which is kind of a really interesting phenomenon. And we'll talk about a little about Delta and sort of how that sort of impacts things. But it seems like if the virus gains purchase in your system, like it can ramp up to about equal levels, right, is what the data suggests, if you've been unvaccinated or vaccinated, which sort of poses some interesting challenges. You get to the next step, right, which is, are you able to transmit it to others, right? So you have this virus floating around your system. You might cough or give off, sneeze or whatever. There's particulates sort of fly off into the air. If you're vaccinated, does it make a difference? Are the people around you less likely to get COVID if you've been vaccinated but still have COVID, right? The numbers here are sort of all over the place. There are a couple of studies out of the UK where they looked at family members of healthcare workers that had been vaccinated and then got the virus. Right. So if you are a nurse in the UK, you get the vaccine and then you get COVID, how likely were you to pass it to your spouse or someone that lives in your household? Right. It was a reduction of about 30 to 50% there. Right. So there were definitely some people in those households that got COVID. Right. But about 50% reduction in those that did compared to like a control group. Right. There's another piece of data that's a little bit wonky, frankly, out of Israel, where they were looking at people that had COVID and were vaccinated and went to concerts. And they came up with an estimate of like 80% of the time, those people don't pass it along to people in their surroundings. So this is interesting to me, right? Because the numbers are sort of a widespread here. It's like 30% protection, 80% protection. It's sort of hard to get a judge. One of the things that's clear, though, it's not 100%, right? There are still people that get vaccinated that are able to pass COVID onto other people, whether or not they are vaccinated, right? Which to me is sort of alarming if you're someone who is banking on the idea of herd immunity, right? So herd immunity being the idea that somebody who has COVID, but there's a bunch of people between them and me who have vaccinated, and those people will sort of insulate me, right? Because the virus can't make it through them to get to me. Well, if the virus can sort of jump to person, regardless of whether or not you're vaccinated, then you have a real challenge there reaching herd immunity, right? Herd immunity is not going to protect you or it's a lot less likely to protect you, I guess, if it can still jump person to person, even though those people are vaccinated, right? So there's something to think about if your particular strategy is herd immunity, right? There are some real challenges in the data emerging to that being true. Okay, get past the point where you can
interrupt real quick. I'm sorry.
Yeah, sure.
Is that not also particularly important data to consider if you have an unvaccinated child who just hasn't reached the age that they've been able to get vaccinated yet?
100%. Yeah, I mean, yep. If you're vaccinated and you come down with COVID, it's not necessarily right. It not necessarily ensures that you won't pass it on to someone in your household. And children who haven't been vaccinated yet, we know, do come down with COVID, right? So that is very relevant. So then moving into the symptomatic infections and severe infections and death, and a lot of this data has sort of come out and it's tracked at the state level. And, Kaiser Family Foundation does a really nice job of sort of putting this data together in one place from different state health agencies. The good news is, and a lot of this sort of has been in the news, is that people that have received the vaccine are way less likely to sort of have symptomatic cases. They're way less likely to be the people that are hospitalized, right? So the numbers here are of the people that have symptomatic infections, like 94% of them or up to 99% of them haven't received the vaccine versus, 0.15 to 6% have, right? That's your balance, right? Symptomatic infections, right? The numbers are even better at the hospitalization level, right? And then death, right? So we are seeing some cases of people that are vaccinated that do pass away from COVID. But the numbers, depending upon the state, are particularly small. And I think the last time I looked, the leader was Connecticut, right? I think it was 0.09% of cases, people that died up to a certain point in Connecticut had been vaccinated, right? It's pretty low, right? So it's pretty good evidence still that the vaccines are conferring protection, if not, spreading, in all cases, preventing it from spreading from person to person. They still do confer a fairly substantial amount of protection if you get the vaccine, preventing it from escalating out of control, leading to hospitalization or death. It's not true in all cases, right? A lot of people have confounding conditions, but yeah, the line seems to be vaccine's still very effective, right, in preventing people from developing really severe cases of COVID infection. So that's sort of the state of the state, right, as far as vaccines go. So Massachusetts, right, the numbers, because we have, frankly, such a huge population that has been vaccinated, right? We're one of the best in the country. The data is pretty good. I mean, it's sort of the good news, bad news, right? Our infection numbers are low, right? They are unfortunately on the rise, right? So we need to be sort of mindful of that. The median age of breakthrough cases is about 82.5, right? So this is a population where the vaccine is likely to sort of probably wear off faster, right? So if you are above 80, we'll talk a little bit about booster shots, because that might be something you are presented with as an option, right? Earlier than other people. Up to, I think this was August 3rd, there were 100 breakthrough cases in the Bay State, which is 0.002% of vaccinated individuals. 73% of those breakthrough cases had some underlying condition. Like they already had impaired lung function, or they already had an immune compromised, or what have you. So the percent of breakthrough cases of people that are sort of fully healthy, very, very, very low, right? Again, breakthrough hospitalizations is very low. 57% of those patients had underlying conditions. And Boston University, we're going to talk about a couple of different specialists at Boston University who do a really good job in this space. they sort of are noting that the breakthrough rates in Massachusetts are comparable, right? We're not seeing an unexpectedly high level of breakthrough cases relative to the percentage of patients in the state that are vaccinated. So sort of a little bit of good and a little bit of bad. Generally good, I would say, right? Massachusetts continues to do an excellent job of vaccinating people, and it's paying off, clearly. All right, so what's Delta, right? So let's start with what a variant is, right? So a variant is a mutated derivative of the original strain of the virus, right? So there are a series of DNA mutations that make up what's called the alpha variant, a different set for beta, a different set for gamma, and then a different set for delta. Mutated variants, so one of the reasons that I guess the primary reason generally that mutated variants emerge is a way for, there are mutations that happen fairly regularly. It's a way for selection to happen for the virus continue to spread in the environmental situation it's in, right? So depending upon what's called selection pressure and what's going on and whether or not the virus is, trying to outcompete other strains, other variants of the virus, you might see certain mutations emerge that sort of allow it to outcompete its cousins. Now, sort of important note here is that variants, again, they sort of emerge as a way to enable the virus to continue to spread. It's not necessarily the same thing as relating to whether or not it's more or less deadly, right? There are a number of cases where variants are more deadly, right? Sort of the more obvious cases are the variants of influenza that go on to be swine flu or avian flu, right? There are some variants where they are less deadly. Sort of the more famous example there, or I guess the leading hypothesis revolves around the influenza outbreak of 1919, right, which was a really kind of very, very dramatic, very, very deadly strain of influenza. And another variant of influenza emerged, right, which replicated faster and spread to more people, but was less deadly, right, and essentially acted as a way to inoculate the population against the more deadly strain, right? So there are cases sort of where variants are more deadly. There are cases where variants are less deadly. Delta seems to be, so far, something that is slightly more dangerous, right? And it is absolutely spreading faster, right? So the nuances of the Delta strain, right, are that there are basically three things that are happening. And these three things are happening as a way to sort of outcompete the other strains that are in the wild. The first is it replicates faster, right? So the original COVID-19 strain that was sort of the most studied one, people got infected and you could start to detect COVID in their system at about 6 days, right? Enough virus had replicated that you could see it through diagnostic testing after about 6 days. Delta, you can see that at about 4 days, right? So the virus is just replicating a lot faster. These mutations allow it to just replicate a lot faster. The second thing is that it reaches a higher number of virus particles, right? So we talked a little bit earlier about viral titer, right? The number of virus particles in the blood of a Delta patient, sort of fully infected Delta patient, versus one of the other strains is about 1,000-fold higher, right? There's just a lot more virus particles in the blood of somebody that hasn't been infected with the Delta strain than somebody with the Alpha strain. And then the third thing it does is there are some mutations in the spike protein, which is the sort of the tree-like thing on the outside of the virus that allows it to go to infect a cell, allows it to sort of attach onto a cell and then break in. And that was the thing that the vaccine is against, right? The vaccine is an attempt to expose your body to the spike protein. It is slightly better, right? It does show some efficacy at avoiding, to a slight extent, what's going on with the vaccine, the immune reaction the vaccine causes. But it is way better, actually, at escaping the immune system of unvaccinated people that have been exposed to COVID in the past. Right, so we talked a little bit at the top about sort of that study out of Kentucky that said reinfection was 2.5-fold lower in people that were immunized versus people that had been previously infected. There's another study out of France that says that number is closer to 4x when measuring what's called convalescent plasma. Right, so there's an assay they do around viral titer or antibody titer there. Net, right? This is not good news for people who sort of are banking on the idea that, well, I don't need to get the vaccine because I had COVID, right? The Delta variant now being the primary variant in the US, this is real bad news, right? So this is something, a piece of information that you might want to sort of consider if your position is, I don't need to get the vaccine because I had COVID, right? It's entirely possible that COVID comes back around, right? And you would get infected again based on the Delta strain. All right. This is a WHO summary, right? Just sort of, this has the 4 predominant variants, alpha, beta, gamma, and delta. There's another one that's not on the slide that is sort of quietly emerging. I think the first cases in Houston were reported last week, the Lambda strain. It's more of the same, if I'm honest. Faster transmissibility, right? And delta, increased risk of hospitalization, right? So that is a little bit more dangerous. Risk of reinfection, right? It is, there's a reduction in some of the neutralizing antibodies in people who have been exposed. There's some reduction in the efficacy of monoclonal antibodies that they give to patients in hospital that have severe cases. So yeah, the variants are bad news, right? These are things that we have to take seriously. They are not diminished forms of the original. These are, frankly, deadlier forms of the original, it seems like. So the big question, or a big question, question I get from family members a lot, is the Delta variant avoiding the vaccines, right? The vaccine's not going to work anymore. And there is some, well, there's some interesting data points out there. The first of which is the Barnstable outbreak, right? So this made a lot of news worldwide. There's an outbreak in Provincetown, Barnstable County, where following one of the event weekends, they found, I think, 469 persons that had COVID infections, of which 74% of those had been vaccinated, right? So that's a pretty alarming number. 74% of the population has been vaccinated and then develops COVID, right? That's not great news. 5 of those people were hospitalized, no deaths. One of the hospitalized was unvaccinated, 4 were vaccinated. There were some underlying conditions, and about 90% of the time, the COVID strain was the Delta strain, right? So this is sort of an alarming collection of events. I will say that there's a really smart epidemiologist out of BU, a different epidemiologist out of BU named Matthew Fox, who is one of the leading voices on this, and he has said a couple of things that sort of bear consideration, right? One of the things he's really saying is that we don't really have all of the information regarding the population, right? So he sort of made a point around doing some back of the napkin math, right? So there were about 60,000 people at this event, in Barnstable County that weekend. Barnstable is one of those places where they have an exceptionally high vaccination rate. In fact, I think they've given out more vaccines than they have people in the town, people in the county. And so, doing some, like I said, back of the envelope math, he made the case that, if 95% of the people had been vaccinated and only 74% of the people that get COVID had vaccinated, that's good news, right? It sort of shows that there's some efficacy from the vaccine. I think more to the point, what he's saying is there's a lot of conflicting variables, right? There's a lot of confounding variables, and we don't really know all of the pieces here. And I think they're still trying to track down a number of people. They're trying to figure out who's exposed. They're trying to understand some of the contact tracing, understand what's going on here. I think what I've seen is that there's a lot of caution being urged around this data, right? It's definitely something to take seriously, and something that's a head scratcher. That number, 74% had been vaccinated, is definitely something that nobody wants to ignore. But there are scenarios where, the vaccine's still working, right? If 95% of that population, hypothetically, had been vaccinated, there are some ways in which this might indicate the vaccine still working, particularly against Delta, right? So I think it's something to be aware of. The jury is still out a bit on this particular incident.
No deaths is a pretty good statistic.
No deaths is good news. Some other data on the Delta variant. And this comes from a couple of different studies in England and in Canada and Israel. And this was published in The Lancet, looking at sort of that progression of confirmed infection to symptomatic disease to hospitalization, right? And trying to measure vaccine effectiveness against the alpha strain, which is the gray dot, and then the delta strain, which is the Delta variant, which is the red triangle, right? And the data seems pretty good, at the hospitalization level, right? There's still very little difference in efficacy, or is sort of the vaccine, the Pfizer vaccine in this case, seems to do a very good job still of keeping people out of hospital, right? It's about the same effectiveness in the study in England, basically the same effectiveness in Canada. And again, you're seeing very little difference in the study in Israel. Where you see a little bit more difference, right, is earlier on in the infection process, right? So you're seeing some people that have Delta are a little bit more likely to be able to see symptoms, confirm the infection, to see symptoms. So the right now, I mean, this tells me, and this is one slide based on a combination of 3 trials of huge numbers of people. This tells me that the vaccines are doing a pretty good job of keeping people out of the hospital. It may be more likely that if you come down with the Delta strain, you are going to see some symptomatic disease, right? But not necessarily to the point of making it to hospitalization. There has been a fair amount of news in terms of boosters, right? So this would be a third shot of the Pfizer or Moderna vaccines. I'm not sure what they would do with some of the other vaccines, to be honest. There, again, a little bit of conflicting information here, right? So Israel, so the health agency in Israel kind of came out and hinted that the population that was earliest to receive vaccination were faring worse than the population that got vaccine later, right? And did that suggest that the vaccine was starting to wear off? A lot of people are kind of questioning that conclusion. I think they particularly tried to vaccinate early on the people that had underlying health issues, right? And we know that that is sort of a confounding factor for people, right? A number of people that we see progressing to severe or death have confounding underlying health issues. So that data is a little, it's still being debated, let's say. Pfizer reported recently that at 6 months, the vaccination was still at least 84% effective. Moderna reported just recently that at 6 months, their vaccination was 93% effective, right? So generally speaking, those numbers are still pretty good. They will obviously continue to track that. They're under obligation to continue to report out efficacy over time, and that will be monitored pretty closely. One of the things that is interesting is that Pfizer has done some initial studies, with their vaccine, giving people a third dose, and they are seeing a 5 to 10-fold improvement in vaccine effectiveness. So seems likely, frankly, that a third dose is coming for people to consider. I believe Israel has already gone to a third dose in a number of patients, and I believe they have seen some success with it, although I couldn't find the actual data to show. So it seems likely, right? It seems that a third dose is going to be up for consideration for people before too long. Boosters, by and large, are effective, right? So what you see on the right here is a couple of, the left 3 are a measure of effectiveness against alpha and delta for people that got 1 dose of, this is the Pfizer, and I believe this one is it's the AstraZeneca vaccine. So you see about 50% or maybe 40% efficacy after 1 dose. You see 80 to 90% efficacy after 2 doses, right? So this is something, boosters work. And I know that, from tracking the data in Massachusetts, is like 10% of people that have gotten 1 dose but not 2. If you are one of those people, you might want to consider a second dose, right? Because the data so far suggests that it does make a dramatic impact against Delta included.
Please call me and I will arrange it.
Then we get into the population that's not vaccinated, right? And I think a lot of us have an interest here, right? Because I have school-age kids. I know Marty has school-age kids. What's going on with kids, right? Why don't we have vaccines for children yet? And what's happening with that population? So I guess first and foremost, the approval or the emergency approval for vaccination in kids is taking longer, in part because the studies around that population they're requiring a longer period after vaccination to ensure that the kids don't have any side effects, right? So they typically did this for about 2 months for adults, but for children, they're requiring, I think, at least 6 months, right? So that's sort of what's causing the delay in getting the data out for children. They're monitoring this situation very closely. Nobody wants to give kids something that's going to make them sick. At the same time, right, the unfortunate reality is that there are 4.3 million children that have been tested positive for COVID-19. The American Academy of Pediatrics tracks this pretty closely. And the number of infections in kids is going up, right? So I believe last week, I think I pulled it today, but I believe the data is as of today. No, it's August 5th. Sorry, it's on the slide. There were 94,000 new cases in children that week, which I think is about the same number of new cases there were for children at the last peak of the pandemic, right? So, there's a population of non-vaccinated people in children, and those cases are, can't be ignored. They're definitely going up. 94,000 cases, by the way, is 2% of all the pediatric cases in the country happened in that week, right? And that number continues to go up. The good news for Massachusetts is it's going up in places where you're seeing outbreaks around the country. They don't seem to be going up dramatically in other places, but it's definitely something that I'm keeping an eye on. And then there is some data to suggest that the symptoms do linger longer in some children, right? So there's a study out of the UK Office for National Statistics that there is, of the kids that get infected, if they're age 2 to 11, they're still showing 10% of those kids are still showing symptoms after 5 weeks after the start of an infection. 7% of kids are showing symptoms after 12 weeks. The numbers are worse for kids that are slightly older. So for kids that are 12 to 16, 13% of those kids are still seeing symptoms 5 weeks after the start of an infection. 8% are still showing symptoms at 12 weeks after the start of an infection. And not necessarily a data point. This is an anecdote that was published, I think, today in the New York Times from a neuroinfectious disease specialist at Boston Children's, talking about, in particularly severe cases in kids, and they're not really able to predict, frankly, who is going to be a severe case in kids. They're seeing fatigue and headaches and concentration issues and sleep issues, and they're seeing it sort of emerge in a number of cases where it seems like the kids get COVID and then fight it off, and then some of these symptoms emerge later on, right? So I think the point here is that there's a lot we still don't know about how the virus infects people long-term, and particularly affects children long-term, right? There's just a lot of variables, and there hasn't been enough time, and there hasn't been enough study. But I know that there's a Center for Excellence at Boston Children's, and they are seeing some things that, again, I think need to be considered. There are, one of the world centers for excellence in this, and they are seeing some of these trends in kids that have COVID. So this is my last slide. What does this all mean? So vaccinations are still the best preventative measure that I can find available to the general population. Again, I'm not a doctor. You need to make a determination with your physician based on what's best, but as a population measure, it seems like vaccinations are still the way to go for all of the strains, right? All of the variants. Second, it's not a great time. It's a really bad time to not be fully vaccinated as an adult. And I guess that's an opinion statement, but I think it's a really bad time to not be fully vaccinated. Previous infection sort of is not offering a ton of protection against the Delta variant. Not getting a booster shot shows a decrease in effectiveness. And again, we talked about sort of that herd immunity piece, right? Vaccines are not fully preventing vaccinated people from spreading the virus. So all of those factors sort of me suggest that, being vaccinated is probably, if possible, something to be considered. be on the lookout for approval of a booster, right? So that's a thing that's likely coming soon. And continue to be smart, right? So I, like everybody, right, on Facebook, watch some of the conversations. I've seen an uptick myself in sort of bad or incomplete or questionable statements in science about, hydroxychloroquine's back and vitamin D's back and the power of zinc. And ivermectin seems to be the little molecule du jour, which is a animal anti-parasitic, I think, right? For which there was a sort of an interesting study in a petri dish of cells that kind of spiraled out of control, the people thinking that was the cure for COVID. I think continue to be skeptical about some of these things and ask around, do some research. And again, if you can, ask an expert. And then do the smart things, just do the simple things, to do the hand washing, do the disinfecting, do the mask wearing where it makes sense. We beat this back pretty good the first time, right, by doing the smart things. I feel like, if we continue to do the smart things, history shows that's a pretty good idea in keeping this vaccine at bay, or keeping the virus at bay. So that's how I'm thinking about where we are right now. Literally right now, like some of the stuff came out in the last week or few days. Things continue to come out, right? So the situation could certainly change, but this is how this is what I'm seeing, and this is how I'm thinking about things right now.
Tom, if you covered this when I had to run away for child care issues, I apologize. But can I ask a quick question?
Yeah.
This is something that keeps getting brought up to me a lot, and it has to do with the history of viral mutation. Did you speak on that?
A little bit. The variants are a collection of mutations, right? What happens is the viruses typically have there's some inherent mutation rate, right? Viruses aren't perfect at making carbon copies of themselves. When they try and make more copies of themselves, there are some inherent mistakes, right? And that sometimes those mistakes don't work well, like the virus works less well. And sometimes there are mutations or collections or multiple mutations that end up working more well, right? So a mutation by itself is not necessarily a detriment to the function of the vaccine. It's how the vaccine evolves, right? The variants that we have here, Delta, is a collection of mutations, right? And that collection of mutations puts a little bit of selection pressure, right, is leading to a variant that replicates a lot faster, replicates at a lot higher viral titer. Right, so it's hard to say specifically that the mutations are not good, right, for the virus. The virus is able to replicate and make it onto the next person faster than the original strain. So yeah, mutations are not good or bad, right? They're just a change. The change itself, how it's manifested, sometimes it's bad and sometimes it's good. It sort of depends what the change itself does.
Right on. And if anybody had any question with any of this data points or any of basically any question at all, you can always send them to me or you can send them to Chris. And if I can't answer them, well, I will ask an expert because, like Tom said, we need to continue to be smart about this, taking our general precautions and doing what we can to stop those who cannot protect themselves from getting infected as best we can, which is our entire goal in the health department. And I'm pretty sure that's the entire goal of the Board of Health and all of the residents who care about this community. Tom, thanks again, man. I can't say that enough. I appreciate you taking time out of your extraordinarily busy schedule to come and do this and hang out with us and just be around to answer questions and to try to be the science communicator that I know you are and that is sorely needed in these times. Someone that can kind of basically interpret things and make them easy to digest. And so I encourage anybody that has questions to let me know. Again, if I can't answer them, well, I know a lot of people that can.
For sure, we can. So thank you. We can find an expert, right? We are blessed in the state with a lot of experts. If you have a question, I'm sure we can track down somebody that knows it better than me. But let me thank you again, Marty. It's been great. I have enjoyed meeting everyone that I met at the vaccine clinics. I have nothing but wonderful interactions with people in the town of Abington, and I'm happy to share. Again, I spend a lot of time researching this, so I can understand it. I'm happy to share what I think I know.
Yeah, thank you.
And we appreciate it. And I want to, Chris, if you don't mind, I want to plug our vaccination clinic on the 25th. The link went out yesterday for people to register. It is not PrepMod anymore. It's a new system called Color. So please go on there and try to fill out the best you can. I'm getting a lot of questions. Is it mandatory? Is it mandated? Has anything changed? And the answer to that is no. I am still a strong advocate for vaccination early and often. So please make an appointment if you haven't. If you have any questions about making an appointment, let us know. Lindsay is in the office. I'm in the office. Lindsay's a brilliant nurse, and she can answer all of your questions just as well as I can. So thanks, everybody.
Thank you. And Tom, thank you. And I just want to reiterate Tom's point about being skeptical. I just wanted to point out, in case people missed it, as Tom was going through his slides, if you noticed he has footnotes, that's citing primary sources for all the information that he gave us. So absolutely, if you're listening to people talk on the internet about what they think they know, make sure they are citing sources. So thank you for that. Marty, just wanted to add real quick, last time I think we talked, Abington was up to 16 active cases. Do you know where we are currently?
14.
14?
So we were able to clear some cases off, and we're having some issues with the contact tracing collaborative right now that we're trying to get to the bottom of.
Awesome. So to reiterate, the clinic is on the 25th. You can sign up through the health department. The links went out to the email. If you didn't get the email or you're not sure, please contact us.
Let me know.
And if you have any further questions, as Marty mentioned, you can reach out to the health department. You can reach out to the Board of Health or me through Abington CAM. My email is on the town website. We're more than happy to answer you directly or address questions in further episodes of the Health Department Roundtable. So Tom, Marty, I want to thank you both very much for your time. It's always greatly appreciated. Stay safe, everybody, and we'll be back at it.